Hello, everyone. I'll give everyone a moment to join. And while we're waiting for everybody, I can go ahead and introduce myself as well as our co-presenters. I'm Dr. Gauri Agarwal. I'm the Associate Dean for Clinical Curriculum at the University of Miami Miller School of Medicine. And I'm joined today by Dr. Jeffrey Manko, who's the co-editor-in-chief of WISE-OnCall from the NYU Grossman School of Medicine, and Dr. Erin ORourke from the Department of Surgery, who's a program director for UME and the trauma medical director at the University of Wisconsin School of Medicine and Public Health. I believe we have about 25 to 30 minutes or so for us to present our material and to discuss at the end and answer any questions. There are also folks that are in the chat that are able to answer questions directly there as well. So I'll go ahead and get started and tell you about my own experience with WISE-OnCall. So in addition to my administrative role, I have a few teaching responsibilities, one of which is the direction of a transition to residency capstone course. In other institutions, it's called a residency prep course or a boot camp course. And in 2016, we piloted it as an elective course. And with those students, we decided to go ahead and implement WISE-OnCall to see what their feedback was and to see if it would be an appropriate way to get them skilled with all of the necessary tools that they need for surviving as interns. I received some feedback from the students that they felt it was a little bit too easy given their developmental stage at the end of their fourth year of medical school. So we decided to actually move it in time to the early part of the fourth year. And in 2017, we implemented it as a graduation requirement for all of our fourth year medical students. So we generally ask the students to complete this early in their fourth year, as I said, prior to their sub-internships. We felt that that's when it would probably be most useful to them to go through these modules. We at our medical school have a number of different sub-internships and courses that the students take at that time of the year. And it was difficult to really parse this out amongst all of our different courses. So I decided to keep it centrally administered. So it's just a graduation requirement of the medical school and not housed within any particular course. And early in its implementation, I was just tracking completion of that using the help from administrators at WISE-OnCall. I now have a staff member who ensures module completion. Generally, my only task is to let the students know about the value of this, remind them to do it before their sub-internship. We give them a deadline of around September. Our academic year begins in June, and we give them until September to complete these modules. And we then pull the roster, follow up with any students who have not completed it. And essentially now this is a graduation requirement for everybody. It's been well received by the students. They do feel it's quite helpful at that point in their medical education. They feel it does help improve their performance on sub-internships. So I'm going to go ahead and hand it over now to our next speaker. This is Dr. Manko.
Hi, everyone. Thanks, Dr. Agarwal. I'm Jeff Manko. I'm one of the co-editors of WISE-OnCall. For full disclosure, I'm also the director of GME Professional Development and Wellness at the medical school and institution, as well as an associate professor of emergency medicine. So one of the things that we've actually used these WISE-OnCall modules for is one of the orientation programs that we've affectionately called First Night on Call. And pretty much what we've done is we've made it available to all specialties and all incoming interns as part of their orientation program, recognizing a few key important things that I think everyone is aware of. One is that sometime between graduation and their beginning as an intern or a practice provider, not necessarily in the COVID era, but something happens when they all travel to Southeast Asia and they all travel and there are these months between when they finish medical school and they begin residency or beginning their practice, that something happens and all of a sudden, bam, they feel as though they've forgotten everything. And we have found that WISE-OnCall has done a wonderful job of providing some reinforcement and review of many of the concepts that they're going to actually need. One of the requirements has been that everyone is required to do at least 5 of the modules before beginning residency, internship, or advanced practice. We have found that most of them tend to do at least 2 more, and many of them do all 12 of them. Next. So some of the pearls that we've learned from the students to practice providers and residents going forward was the receptors are primed for learning at this point in time. And I think fear is a really good motivator because something actually happens where they realize, oh my God, I'm the person on the phone that's being called as the doctor, and I'm the one that's supposed to come up with the answers, and I'm the one that's supposed to know something. And so their receptors, like we said, are primed, they're ready to learn, they're eager to learn, and they actually find it very engaging. About that, once again, many of them need to be re-engaged in clinical medicine. There's often a time lag between the last time that they saw patients on the ward and where they're going to see them. And so this provides them the opportunity to re-engage with clinical medicine. One of the other things that winds up happening is whether they're interns, PAs, advanced practice providers, they should all know common presentations of medical complaints. I like to call that the nurse is going to call you for something, and it's probably a good idea, excuse me, that you have a basic idea of anything that they could call you about. They could call you because the blood pressure is high. They could call you because the blood pressure is low. And the idea is that this WISE-OnCall and WISE-OnCall modules present very common presentations, often what we like to call the nurse on the phone says the patient is complaining of, and then the practitioner is able to then handle that. It also ensures that all the incoming residents have a uniform learning. Everyone comes in with different experiences. They come from different medical schools or they come from different learning programs. And this is a way to kind of make a uniform learning environment for everyone who's coming in. We've made it part of the onboarding process. So pretty much if you want to get a paycheck and you want to start, working in your job, it's a good idea to make it part of onboarding, and then it's obviously required. And once again, it's applicable for, if not all specialties, at least most specialties, because the incoming providers, whether they're interns or PAs or nurses or advanced practitioners, they're all stem cells at the time in which they start because they've all had similar training before they actually differentiate into their specialties. Next. So this is where really the rubber meets the road and the proof is in the pudding. We surveyed the 200 incoming interns that we had this year for our first night on call. And these are the two questions we asked. We said, did you feel that it provided a framework to organize your clinical information? And did you think it improved your level of readiness for internship or to begin practice? And as you can see, overwhelmingly, around 90% or so felt that it really was a valuable experience to them to begin their new practice life as interns, residents, nurses, PAs, or advanced practitioners. So I will now hand it over to Dr. ORourke, and thank you very much for allowing me this time to talk about WISE-OnCall.
Thank you. Thanks everybody for having me. My name's Erin ORourke again. I'm at the University of Wisconsin, and I'm on the leadership team for a large curriculum transformation that we have undergone in the last few years at the University of Wisconsin. But I'm mostly responsible for the surgical component of education through all 4 years of medical student education at UW. The real UW, if anyone from Washington is on, I claim UW for Wisconsin. But I wanted to talk about today what we do with the WISE-OnCall modules for our senior students. We have a 3-phase curriculum, and our first non-clinical part of our education is a 1.5 years. Then our students, which would traditionally be third-year students, are here with us for a year in phase 2. We consider those our undifferentiated medical students. And then what would, in most people's mind, be a 4th-year med student is a 1.5 years long. And when they are where they are allowed to do a little more career exploration and then do all of their graduation requirement courses for senior students, but we consider them a little bit differentiated and let them tailor their curriculum for what will prepare them for intern year and whatever their chosen specialty is. And we, much like Dr. Agarwal, have both acting internship coursework for our students in whatever specialty they choose, as well as an intern prep course at the end of their phase 3. And so for many of our students, that's separated by over a year in time. for them. And we use in our surgical acting internship, which includes not just general surgery, but all surgical subspecialties. So we put them off in their clinical settings, but have case conferences for all of our surgical subspecialty students, including orthopedics, ENT, plastics, neurosurgery, general surgery, urology. And we have chosen the 8 modules that I have listed here in our 4 weeks. In the first week, we do case conferences where they've been responsible for reviewing the modules on acute pain management and abdominal pain. We tried to pair them together in ways that we think makes a little bit sense for a surgical practice. So chest pain and dyspnea come together, oliguria and hypotension, and then in the last week, we discussed leg pain, and then we spend a short time discussing declaring a death because it's produces so much anxiety for our new learners. And then we re-look at that content again in their boot camps. And as was pointed out in the earlier slides, the way that the WISE-OnCall modules are organized is there's actually a roadmap for how to proceed through a problem, and there's a checklist that floats off to the side. And so we really try to work through problems together in our case conferences using that checklist. And then again, when we go into our boot camps and we do simulated scenarios of oftentimes the same sort of cases we discussed back in the acting inpatient internship, we actually provide them with the checklists. The first year I did this, I split my students, half got the checklists and half didn't, to see how they did. And there weren't enough students for me to draw any conclusions, but the biggest thing was that the students who didn't get the checklist were like, how come we didn't get the checklist? It's way better. And I've checked in with some students who've since graduated who have versions of that checklist they carried around with them on their phones at the beginning part of their intern year to help them work through problems. And really sort of revisiting that content, starting with it at the beginning of their phase 3 and then again at the end of their phase 3, I think, and seeing it in 2 different learning environments, really 3 different if you include a case conference where we're discussing actually on the wards and then again in a simulated environment, really solidifies that content because you're visiting it in different ways and different times in your education. We found it to be helpful. The original 4 we chose were just because it was the only 4 modules that WISE-OnCall offered. And as the modules have grown in time, we keep adding more and more in. The modules that we don't include, we encourage the students to review on their own. And then the other thing I think we really use it for is to try to build our learners' confidence. As Dr. Mankow pointed out, they're super anxious. They're primed to learn because they finally recognize that there is this responsibility upon them. And we actually go around and make every one of the students tell us which thing on the differential for chest pain and dyspnea scares them the most about their first night on call. And they're all scared of something different. And we then try to break it down. Okay, well, what scares you about that? And then we go through working through the problem to try to demystify how terrifying it is and that how much control they have over the situation and how they can manage it and how they call for help. And then we do that again in simulations so that they're not absolutely terrified to start their intern years. I mean, a little healthy fear is good. We all have a little bit of healthy fear, but we want them to be inspired and confident when they're hitting the wards and when they get out and are ready to begin their practice. So that's how we use the WISE-OnCall content at the University of Wisconsin. And I appreciate the time to share with you all, and I'm happy to take any questions.
So I think it's our time now for open discussion. I don't see any questions in the chat.
Dr. ORourke, I was wondering if you could describe some of the other student reactions to the WISE-OnCall modules.
So they really enjoyed the modules, and not to say anything about the WISE-MD modules because I have my students in phase 2 using those modules as well for some of the content that they might not be exposed to. Universally, they prefer the WISE-OnCall modules to the WISE-MD modules. I think because they're a little bit more interactive. And one of the other things that I've had a few students point out to me is that they appreciate the modeling of what would be considered a professional interaction. So not just here's how we work through the problem, but actually this is how I would respond to a nurse when a nurse pages me, because our med students don't get the opportunity to be paged and be the person answering the phone and answering a question. So the modeling of professional behavior has been noted by some of my students to be very much appreciated. And hardly any of them have ever had to go in and declare somebody dead. And so we talk about what to do and how not to be awkward if the family's in the room when you walk in to declare a death, just to try to demystify something that nobody really talks about. So that's what my students have told me.
Dr. Agarwal and Dr. Menko and Dr. O'Rourke, thank you for your presentation. We do have some non-physician attendees to the webinar. From your vantage point, because you work in these interprofessional environments, how do you believe that other disciplines could use WISE-OnCall and WISE-MD? Or WISE-OnCall, rather, I'm sorry.
Well, personally, at both NYU and Bellevue, we work with nurse practitioners and physician assistants at our side each shift all the time. And so I think that the cases that they see, the problems that they're asked to solve are very similar to those that we have for our house staff. And so the information, the knowledge, and the experience of learning how to handle the undifferentiated patient with dyspnea or chest pain or abdominal pain certainly is as important to anyone who's going to be at the bedside taking a physical and history for any chief complaint. And we found that the advanced practice providers have enjoyed and been engaged with the WISE-OnCall modules, as have the house staff.
We don't personally use it for anyone other than our medical students currently, but what Dr. O'Rourke was saying about the confidence of going through these modules and feeling like you can handle these situations, it's universal, right? And so it's actually something that from this webinar, I'm going to take back to our institution to talk to our other, healthcare programs and whether they'd be interested in this, because I do think it's of great value. I think I agree with Dr. Menko that the knowledge base and having that systematic approach in a simulated environment puts everybody at ease, that they can actually handle this in real life.
Dr. O'Rourke, we found interesting how you tied in the modules with the simulated scenarios as other centers. Can you talk a little bit more about what your simulated scenarios look like and how you tied them in with the modules?
Certainly. So our simulated scenarios in our boot camps, it's not entirely just surgical. It's not just learning how to fire the staplers and working in the operating room. We recognize that surgical junior residents really spend the majority of their time caring for our inpatient surgical patients in the perioperative period and need to be prepared for all of the same sorts of on-call questions that you would for any residency. And so we create several simulated scenarios where it starts off with the student in the room already. They either have a confederate with them who serves the role of a nurse, or there's one of us in the control room on the microphone, and we will begin it with a phone call about Mr. Jones, who's in front of you, who might be the mannequin, and they're complaining of chest pain. And then we have them actually just verbalize what sorts of things they might like to order or ask questions to whoever's paging them. And then they move to whatever the scenario is. And with our sim lab, we can actually have their vitals broadcasted. We would throw up any films that they might have asked for. You have to prepare for how they might work through the problem. So you often have to have more than one, an x-ray when maybe you wouldn't want an x-ray or something like that, so that you can work through the problem. And then they now, like all of them, have the checklists so they can help not be very anxious while they're doing through it. And then after enough students have gone through the scenarios, we do a debrief together because they don't always get to the same answer. We've had a patient that has had escalating chest pain, so we'll work them through someone having angina and then going on to developing a STEMI. over the course of even a couple days simulation, actually. We're fortunate, I guess unfortunate, I would say, we don't have as many. Our boot camp is a university-wide, or medical school-wide. All students do a graduating boot camp, but because the number of students going into surgery compared with other specialties is not as large, I think we're able to have a pretty robust and a little bit more intimate simulation environment than if you were trying to do that with a large class of students, say 140 students. If I'm doing sim scenarios for 15 or 20 students, I have enough faculty buy-in to do some pretty robust simulations.
Dr. Menko, do you think that you can talk about the, what do you think are the most popular modules to assign, and why do you think that they are?
I'll tell you, I think that, as my colleagues had said earlier, the things that make them very nervous are the ones where they're the highest acuity and the most critical care, where it feels as though the lives are in jeopardy. So I think that hypotension, fever and sepsis, chest pain, shortness of breath, and abdominal pain catastrophes are probably the ones that most of the residencies and most people find most valuable. Not that they aren't all valuable in their own way, but I think that the things that scare them the most is the acute abdomen, or the person coming in with undifferentiated shortness of breath and chest pain. And that was even before COVID. And I think that fever and sepsis and hypotension is another big category that people feel particularly, that they really feel is an important concept to learn. And I think, as Lynn pointed out in the main session, a lot of those modules also, the experts that we have gone into real depth in terms of the pathophysiology and the physiology involved in hypotension and sepsis, so that it really makes it much more understandable for both beginners as well as intermediate and some advanced. I think we also find that some of our learners use these modules for on-time or just-in-time learning. So they get that phone call from the nurse that says, Mr. Jones has, and you can put in the chief complaint, and they're able to go to the WISE-OnCall module and look at the checklist and look at some of the things that they're able to ask and think about at the bedside before they even go there.
Hi, everyone. We actually have Cindy Lorde, and she's a PA director, and she's going to speak a little bit about how she's using WISE-OnCall in her second year clinical PA student program. I'm just going to ask her to unmute.
So I just had put it in the chat. Hi, everyone. Thank you for a great presentation. We love your product. So as a PA program director, the WISE products have been very useful. And so we use WISE-MD in the first year in our surgical program, and then we reuse it in their surgical rotation in their clinical year. For WISE-OnCall, we're using it with our second year students kind of in the second half. They're kind of starting to see the finish line and thinking about jobs as part of our transition to practice curriculum. They're going to be at the bedside in 27 months. They're not doing a residency, an internship. And so we need to make sure that they are ready, and they have the same fears. And I think, Dr. Menko, you expressed that when you see your APPs, they have the same chief complaints and the same issues. So I just wanted to let you all know that it's, as well as being a clinician, APP, good for them, it's also good for those PA students who are rounding the corner in the last part of their clinical year. And so we assign it as part of their rotations, and we mix it. It's not just surgery. I mean, we put it throughout the curriculum, whatever they're doing in the last kind of third of their clinical year.
Cindy, I don't mean to put you on the spot, but do you think that this would also be appropriate for practicing PAs that have already transitioned in?
Absolutely, but I also think it's great. A lot of healthcare systems, so I'm in Cleveland and I'm at Case, and so we work closely, obviously, with Cleveland Clinic, and they have they're one of the largest employers of PAs, probably in the country, but certainly in Ohio, and they have a transition to practice program for their 600 plus PAs as they come on board, and this would be a beautiful product for them as well.
Thank you, Cindy. We have about a little less than 10 more minutes. Does anybody have anything else in the chat that they would like to add?
Joanne, this is Tomriles. Can you hear me?
Yes, we can.
What I wanted to point out that this is still a project that's under development. Obviously, we've come a long ways in the 4 or 5 years, but these modules do take a long time to craft and to get them right and make sure that the educational points are made throughout the module. But we're still interested in building more. So one of the things that we will be very interested in learning from our medical and PA schools and nursing schools is what other modules would be a benefit to their program, because we will be making more. We have some of our own ideas, but that will be something we'd like to hear about going forward.
Also, if anybody has these ideas that come to them in the middle of the night and they'd like to let us know, we are available at wise@nyu-langone.org, and we will be sharing that with everyone, I'm sure, the contact information. We're still monitoring the chat.
Joanne, this is Lynn Buckvar-Keltz. I just wanted to reemphasize one of Dr. O'Rourke's points, which is the use of some of the modules for students who may not be seeing some of these issues on the ward. So I think certifying a death is a perfect example of that. It hopefully happens infrequently, and there may not be the opportunity for students to be, or learners to be, shadowing and observing the discussion with the family, the going into the room to actually examine the patient, think about all the different steps involved in certifying a death. And so I'm glad to hear that that's one of the modules that's used, and it's something that is very scary for our learners, and it can help demystify the points in the process, as well as role model. We spent a lot of time carefully thinking about how the video would go and how the discussion happens with the family members, etc.
Since we have a little bit of time, I'll tell you the reason that I use that module is I have a dear friend who has a story from when she was a senior practicing nurse in an ICU, and a brand new intern they called and said, you need to come in, Mr. So-and-so has passed away, we need you to come declare him. And the intern didn't know what to do, and the nurse jokingly said, well, what you do is I want you to go in the room and stand at the foot of the bed, and I want you to hold your arms up and say, by the power vested in me by the state of Tennessee, I now declare you dead. And that's what that poor intern did. And the nurses howled with laughter at him and teased him about it through the rest of his residency. He was very scarred from this. And so I just didn't want that to happen to any of my students when they went and got into practice.
I have my own horror story from when I was a beginning intern, and I was asked to speak with a family about the death, the sudden death of a loved one in the middle of the night. So yes, I think it's one of those areas in medicine that until you're exposed to it, you really have no idea, what the steps are that are involved.
I think we may have time for one last comment. We did get a comment from Kay. Kay, I'm going to ask that you unmute so you can speak to the group.
Am I unmuted now?
We can hear you, Kay. We can hear you.
Oh, okay, super. My computer's telling me I'm muted. Sorry, my video is muted. I guess I'll tell strangers I'm on vacation, and so I'm still in my PJs and I need a shower, so I didn't unmute my video. But I was just saying, we just got these, and I'm so happy because I've been pushing for a long time to be able to have these things. And so I don't know if these are part of the modules, but I certainly would be interested in, as a suggestion, things that might have to do with social determinants of health, or diversity, health equity, inclusion, those sorts of things, if not already incorporated in what you already have. And so that was my suggestion in the chat. Oh, hi, Scott Harris. I'm good.
Kay, where are you calling from? And what is your role in your institution? Just
California, and I'm a professor of family medicine.
thank you so much for your input.
I think that's a great idea. Thank you for that. I will say that by role modeling, we've been taken care to show a diverse workforce in our different modules. So you'll see physicians of all races and ethnicities. You will also see patients of different races and ethnicities and other people on the care team as well. But we have not directly approached the social determinants of health, and I think that's a great idea of an addition of something we can work on and really help model how you would go about assessing that with a patient.
Dr. Buckvar-Keltz, that's an amazing suggestion. It might be interesting in the simulations as well.
Right.
We have about 5 more minutes. Does anybody have anything else they would like to add or ask?
I might say one more thing. This is Tomriles again. Is that the professionalism, working that into the modules, was a very interesting idea. That we have done modules strictly on malpractice and professionalism of that sort, but the more subtle things that aren't taught, we tried to work into the module. For example, in one of the modules, you'll see a young intern talking to a family member, and a nurse comes up and interrupts him, just starts speaking to him, and the intern takes the time to apologize to the patient, the family member, saying, excuse me, would you mind if I take this message? So he doesn't just walk away and leave the guy hanging there. So little things like that are kind of worked in all throughout the whole series of modules that we think that was kind of important. And every module has at least a nurse or a PA or some sort of a healthcare worker working alongside the physicians in these cases. And we certainly would like to expand that going forward.
I'll just add your question, Dr. Riles, about things that we would want from doing our boot camp course. I know, and even national data from program directors about where interns are really lacking sometimes in skill sets is not just a professionalism piece, but the communication skills piece. And I know there are a number of products that relate to communication skills, but conducting a family meeting, for example, it wasn't something that we explicitly taught anywhere else in our curriculum. We saw in our boot camp course that there was a real need, but what is the actual way to organize that? How do you delegate tasks and go through the steps of doing that? So that's one example. And then to the question about diversity and equity, we actually added this to our transition to rotations course for our third-year students, but we didn't really see any great curricula out there about how to conduct crucial conversations, right, as we call it, with family members or patients, especially when there's an uncomfortable situation where your implicit bias may be playing a role. And how you might react to patients who want treatment that you're not comfortable with, that's outside of biomedicine, or they may say something that's uncomfortable to you personally as a provider. So all of those are examples of communication skills modules that we would love to have all in one package.
Right, and as part of our first night on call orientation, we have things like getting informed consent, giving handoffs, the idea of escalation in the situation of a hypotensive patient with sepsis, with the idea being that they're also learning some very important communication skills, learning about reporting medical errors, learning about, recognizing adverse events and feeling comfortable having those difficult conversations with patients. So I think I agree with everyone that the professionalism part, the crucial conversations, those things that we all shudder at ourselves, but have learned how to do it and learned how to hopefully teach it, That's another one of those areas that learners are nervous about and obviously need practice and need time to gain experience.
This is Eileen Oshesky from Aquifer too. I just wanted to point out we've got a Teaching Perspectives and Pearls blog up at aquifer.org under our resources section. And there's a post that was just put up recently about using one of our free courses, High Value Care, along with a different subscriber course, Geriatrics, but some students designed a course on having difficult conversations. And it's pretty neat. It includes TED Talks and poetry. As I said, some of our free content. So not necessarily related to this course, but you might want to take a look at it. And the free content's obviously available.